Presenter will be Dr. Michael Choti. Dr. Choti received his medical school education at Yale University, followed by general surgery training at the University of Pennsylvania. He then moved up north to Memorial Sloan Kettering to complete a surgical oncology fellowship. Dr. Choti is a well-known hepatobiliary and surgical oncologist. He used to be the chair of the NCI CTEP Hepatobiliary Task Force, and he currently serves as the chief of surgery at Banner MD Anderson Cancer Center in Phoenix, Arizona. He will be speaking to us about surgical management of Hilar Cholangiocarcinoma. Dr. Choti.
Thank you, Flavio. Thank you for the organizers and the sponsors. It's terrific to be back in Taiwan, and thank you for being asked to give this talk. So we're going to focus on the surgical approaches and challenges in Hilar cholangio. You've heard a lot about the diversity in the biology of cholangiocarcinoma earlier this morning. I would argue that the surgical diversity of cholangiocarcinoma is probably the widest spectrum that we often deal with, from intrahepatic, as you heard, distal cholangio, gallbladder cancer, and hilar cholangio, all different operations, all different surgical strategies. So it's really a spectrum, a diverse spectrum of surgical management. And perihilar or hilar cholangio is probably among those the most complex, the most challenging, not only for the surgeon, but for the patient. In part because it's best managed. This is complex surgery, multimodality management that often necessitates regionalization in a high-volume specialized center. It's often difficult for patients to get this approach. Determining, as we'll talk about, determining resectability, determining even biopsy, tissue diagnosis is often challenging. Concurrent issues with the cancer, such as liver dysfunction and cholangitis, make particularly surgical approaches challenging for this disease. And resection is complex with high morbidity, again, necessitates often experience. And even then, even experienced hands, as we'll talk about, our outcomes are really not that good. And even our palliative options, as you heard, lots of challenges and lots of controversy. So I'm going to touch on a brief outline, a little bit about preoperative assessment, preoperative preparation, the extent of surgery and the outcomes, and a little about resection versus transplantation, although you'll hear more about transplantation from Dr. Lunsford in a future talk. So defining resectability, much like you've heard about in intrahepatic cholangio, is particularly challenging with this disease. As with other malignancies, there are patient-related factors that determine resectability, factors regarding the spread of disease, nodal involvement, and distant disease. But in hilar cholangiocarcinoma in particular, it's these local regional factors that often are the most challenging in determining whether it's resectability. The extent up the bilateral radicals, the so-called bismuth class 4, encasement or inclusion of the ipsilateral contralateral vessels that may preclude resectability locally, extension or atrophy. All of these factors are often the most challenging when determining resectability in these patients. You've heard a little about, so the T stage is particularly important in hilar cholangiocarcinoma. The AJCC staging system is largely based on the pathologic outcome, so it predicts more prognosis based on pathology and based on postoperative. But you can see similarly with regard to the T stage for hilar cholangiocarcinoma, it's the T4 that typically are defined as unresectable, and you can see in the eighth edition invades the main portal vein or branches bilaterally in the duct, which determines the extent. These staging, you heard about the bismuth classification, which defines stage, the class 1, 2, 3, or this is really where the determination of resectability. The bismuth class 4, when it's involving bilaterally, of the ducts bilaterally, beyond the secondary radicals, that these patients are more often determined to be unresectable versus the other. But the Jarnigan or the Bloomgard classification attempts to use the vascular involvement contralateral that helps somewhat. So you could see a T1 is if it's unilateral in the duct, T2 if it's unilateral involvement with unilateral or ipsilateral vascular involvement, or ipsilateral atrophy. So these are resectable. And the T3s are often the challenge. Bilateral duct above the secondary radical, unilateral extension on one side and contralateral vascular involvement or bilateral vascular involvement. So these staging forms are typically used preoperatively, not as predictable for prognosis, but useful in determining resectability. So as we've heard in excellent talks this morning about imaging and preoperative drainage, assessment of the biliary tree, very important in determining the extent of disease. As I mentioned, so important to determine the extent of disease both in the adjacent vasculature and also extension along the biliary ducts, but this is not really that easy to determine preoperatively. So the important anatomic considerations in the hilum are particularly important. For example, the left bile duct typically drains into the caudate lobe, so caudate resection is important in tumors that involve left hepatectomy. And left-sided tumors are often less resectable, in part because the relationship between the right hepatic artery to the bifurcation often precludes the ability in tumors that extend up the left side to necessitate either unresectability or reconstruction of the right hepatic artery. And the other reason is that the bile duct segment is shorter on the right before it begins bifurcating compared to the hilar plate, if you will, or the length of the left bile duct, such that tumors involving the left side are more often become unresectable than tumors on the right side. So left hepatectomies are somewhat less common. What about preoperative evaluation? As you've heard already about, imaging of the biliary tree is critical, of course, in assessment of resectability in ERCP or percutaneous transhepatic cholangiography. Both are important to determine, at least from the interluminal extent of the bile ducts, to determine the stage or the extent in the biliary tree. MRCP shows you similar information with regard to imaging of the biliary tree itself. And cross-sectional imaging, of course, is very important to determine the extent of soft tissue extent, atrophy, metastatic disease, remnant volume, all are important features. So both imaging of the biliary tree and cross-sectional imaging of the liver is important in assessment preoperatively. In fact, as you already heard, MRI combined with MRCP is probably the modality we use most to determine, because it really gives you all the information or most of the information you need. Not only can you, again, as I mentioned, you can get good imaging of the biliary tree to see the extent, but also it provides all the information, or at least we hope to determine presence of or absence of metastatic disease. One can determine volumetric in the presence of atrophy. One can determine the local soft tissue extent, at least as best that these studies can image, and adjacent vascular involvement. So I would say largely that MRI and MRCP, preferably prior to any stenting, is really the best imaging modality we have, at least to date, to assess resectability in these patients. So it's very important in determining this. It's important to get high-quality imaging, and it's important to have a multidisciplinary team that evaluates this in order to offer the best approach for our patients. You already heard there are other imaging modalities: intraductal ultrasound, cholangioscopy, even some new modalities of intrabiliary MRI, all in hopes of better determining resectability prior to operation. But in fact, we still, as we'll talk about, still have some challenges in determining resectability. So what about preoperatively? And we've already heard in preparation for a potentially resectable patient. You've heard of it. I won't spend a lot of time. The role of preoperative decompression is controversial. We typically, in spite of the data that you saw that suggested, in fact, these patients who are decompressed preoperatively do worse, it's not uncommon. I would say it's the majority of patients that are sent to me with potentially operable disease already have stents and we often, in fact, decompress them in patients that are significantly jaundiced preoperatively. The role of preoperative portal vein embolization for preparation of the ipsilateral, eliciting hypertrophy of a potentially small remnant in the liver, somewhat controversial, and other staging such as PET scan and staging laparoscopy, somewhat controversial in this disease compared to others. If you look at the data of FDG PET, again, it's mixed data whether this is of value in this subset of patients. So these tumors are often infiltrating. There are stents in place that could create false positives. In fact, the data on the classic infiltrating Hilar Cholangiocarcinoma suggests that FDG PET is probably not as useful to really determine resectability, in part because, as I mentioned, it's often local resectability that's the challenge and not the presence or absence of distant metastatic disease that determines resectability in these patients. Staging laparoscopy, I think, is controversial. We clearly do this in most malignancies. If you look at the data, however, also these are early data on PET scans suggesting that while the yield in patients who have higher risk for metastatic disease, such as gallbladder cancer, is pretty high, in patients with Hilar cholangiocarcinoma, it's often difficult to determine resectability intraoperatively because it's often some local factors. Although I must say that we're better at this approach. Staging laparoscopy is relatively easy to do. So I think, at least in my practice, I typically still do staging laparoscopy when exploring patients at the time in planning resection of Hilar cholangiocarcinoma. So what about the resection? Well, it's critical that achieving an R0 or margin negative resection is important. These are early data showing very clearly that, and we know evidently that in patients who are resected, that patients who can achieve a negative margin do better in long-term outcome than patients with a positive margin. But you can see in this early series from Memorial, first of all, look at these numbers. 50% of patients that are explored even had a resection, and margin negativity was achieved in only about 3/4 of patients. And I would argue we haven't changed that much in most current series. The goal of resection is, as I mentioned, complete resection. And I think that it's pretty established that while historically there was some question as to whether hepatectomy would be required, the data is pretty clear that excision of the bile duct and routine hepatectomy with caudate in the term of left resections in order to achieve negative margins, that is the operation. That's the established procedure with, of course, restoration of the bilioenteric hepatico-jejunostomy in order to reconstruct the bile duct. Controversial as to whether to do routine lymphadenectomy in these patients, although and others typically recommend it, and it's some controversial as to whether to do the vascular ipsilateral or vascular reconstruction, let's say of the main portal vein, when those vessels are involved. Some would suggest that if the artery is for example, the main artery is involved, that it's contraindicated to reconstruct that, or to reconstruct the portal vein. Those operations, it's associated with a higher morbidity, but I think that still, in selected cases, major vascular reconstruction may be indicated in patients where those vessels are involved. What's quite controversial, and I think few are doing, is routine main portal vein resection, in part because of the proximity of the tumor to the main portal vein and the bifurcation. Some have argued that portal vein should be resected always. I'm not sure that has really gained traction in most recent series. What about the morbidity following this, what's typically a major hepatectomy, often in patients that are jaundiced and which require biliary reconstruction? These patients have a higher mortality and a higher morbidity than even routine major hepatectomy. If you look at the data on the liver regeneration rate in patients that have extrabiliary reconstruction, the regeneration rate is less, and that the postoperative hepatic failure is somewhat higher in patients where there's a same volume of liver resection, but often with potentially jaundiced patients, or when there's a biliary reconstruction. The data shows no question that the outcome is worse, and this one study suggested reported a postoperative liver failure rate of 24% in patients that have major hepatectomy for Hilar cholangiocarcinoma. 12% of the mortality, liver failure-related mortality in this series. And in this series, they reported the risks for liver failure: small future liver remnant, less than 30%, patients with elevated bilirubin preoperatively, and patients with preoperative cholangitis. So as you heard the tension, biliary drainage, on the other hand, is useful. Draining the remnant side can then reduce the preoperative bilirubin, which may reduce risk. On the other hand, stenting can often be associated with an increased risk of cholangitis. So these are challenges in how to manage these patients. So no question, the risk is higher in this reconstruction procedure. What about the outcome? How successful are we at this? Well, the data is a little bit variable in the literature, but unfortunately, the story is not as optimistic as we'd like. This is one series from 3 centers, 2 in the Netherlands, as well as New York, that looked at this question in retrospective cohorts of series and reported in 671 patients, combining the 2 of the total cohort among all and it's a relatively recent series in the last decade or so, although the memorial data went back several decades. You can see that in this series, only a similar trend, only 50% of patients who underwent, after adequate staging, as I described, still 50% of patients not resected at the time of surgery. Sobering numbers. And even among those that are operated on, 25% are margin positive, so only 75% of the 50% that have had a resection achieve that goal of margin negative resection. In this series, 13% 90-day mortality. So they reported in the series that underwent surgical exploration at these high-volume experience centers, 30%, quote, successful surgery. That is, survived the surgery and were margin negative. Here are the data, and we're delighted to have our experience here from Nagoya. We have Professor Nagino, who will be talking to us next, and the outstanding series, probably one of the leaders and largest series to report this from Japan. Here you can see the series of reported here in 2 eras or 2 decades. These outcomes were somewhat better in this overall period. They reported a resectability rate of 76% and 67% achievement of R0 resection. This study, published in 2013, showed that the outcomes, survival rates in the earlier era, in the 90s, if you will, with 5-year survival rates of 23% compared to the more recent era, where the 5-year survival rate around is 38%. So we're still not great outcomes, but at least these numbers are encouraging. An update of the Nagoya series showed here long-term outcomes of these patients, reporting over 400 patients, again, 85% R0 resection rate. Interestingly, we mentioned cholecystoscopy in determining the extent of resection. As many feel, the margin positivity rate is not always in the duct, but in the periductal tissue that can't always be determined by interluminal imaging. In this series, with a long-term follow-up and consecutive imaging series, they report, you can see here, the overall survival rate, about 50%, 5-year survival rate, about a third are surviving at 10 years in patients with R0 resection. You can see the numbers are worse with R1 long-term. If you look at the recurrence-free survival in this series, still with an R1 resection, which happens in about a fourth of the time, recurrence rate is very common, and long-term outcome in patients with an R0 resection, still 38% recurrence-free survival at 5 years. 9% of the recurrences occurred beyond that time. So you've heard a little bit, so we clearly need to do better than just surgery. You heard from the previous talk about some new strategies, perhaps neoadjuvant therapy. We're not doing that currently, of course, for this disease. We'll hear some more about the adjuvant data, including the BILCAP trial that suggested some benefit of postoperative capecitabine. In this series, 35% of patients had Hilar Cholangiocarcinoma, so certainly we need to have better approaches, whether that's neoadjuvant therapy, better staging in this high morbid operation. What about the pattern of recurrence? This is the historic report that, gallbladder cancer has a high risk of distant recurrence, but hilar cholangio, it's all about local regional recurrence. That's why the strategies of transplantation and others, it's all the margin issues. But if you look at these data, it's probably not as obvious as we think. 2 series, one from Nagoya and another from multi-institution, including Memorial, suggested that local recurrence alone, isolated recurrence, is not that common. In this series of R0 resection, only 18% had an isolated local recurrence, and it was associated with close margins. In the Nagoya series that you could see, the local recurrence of if an R0 resection was still uncommon at about a third, even in margin-positive patients, distant or both is still the majority of cases. So while we think that it's a local recurrence is the main problem, many patients either still develop either distant or combined local and distant recurrence in these patients. Finally, just a brief word on transplant. I mean, it certainly makes sense. Local recurrence was considered a problem. That's the ultimate margin negative resection is a complete total hepatectomy. Early data suggested that these patients did not do well compared to series of non-cholangiocarcinoma. More recent data from Mayo and others with an aggressive neoadjuvant strategy suggested that outcomes were better than that of resection. That's gained a lot of enthusiasm. In this series, you could see 5-year survival rates, intent to treat, that was considerably better than most series of resection for hilar cholangio. If you look at recurrence-free survival in this series of patients who met the UNOS criteria, long-term outcomes that were outstanding, suggesting that this may be an approach. But again, these are very highly selected patients. If you looked at least series that tried to compare resection to transplant, I think the data, even for N0, R0, it looks like the data is still not clear as to whether transplant should be superior. And there's certainly problems to the transplant approach. Many patients, really, these are highly selected patients. Many patients drop out based on abdominal exploration and may be subjected to extensive and toxic therapy and then cannot then get the transplant. Are they actually worse off than had they not undergone these local detoxic therapies? There's still a relatively high complication rate for transplant after neoadjuvant therapy. It may be due to selection. These patients are highly scrutinized after preoperative treatment and duration, and so perhaps we are comparing somewhat apples to oranges, if you will. Many patients did not even have biopsies, and many of those there was no tissue, no malignancy in the explant, so there may be some selection bias there, including the presence of PSC. So we still don't know the role of transplantation, I think, for hilar cholangiocarcinoma, either resectable or unresectable. So in summary, complicated from a surgical approach standpoint. It's a complicated disease to manage, very difficult for patients, very difficult for surgeons and for all of us. The goal is achieving complete margin negative resection. That is the goal. It's difficult to achieve and difficult to determine. We've had significant advances in non-invasive imaging that have allowed us to better determine resectability. High-quality imaging, multidisciplinary teams, high-volume centers are probably the important strategy in order to deliver the best care for our patients. The role of PET laparoscopy is controversial, probably not indicated. The strategies of using portal vein embolization, biliary drainage, I think those are potential strategies, but still are somewhat controversial in this disease. Yet in spite of improved preoperative imaging, still unresectable disease is still reported in patients that undergo surgery, still as high as 35 to 50% of patients, which is probably too high. Even among resected patients, we see margin positive resections in 15 to 25% of patients. There may be a role in liver transplantation, but improved adjuvant and neoadjuvant strategies, as you've heard with intrahepatic cholangio, I think that same approach, same strategies will need to be done and will likely play an increasingly important role in the management of hilar cholangiocarcinoma. Thank you very much for your time.
Any questions for Dr. Choti from the audience? If not, I'll start. Mike, since resection or transplant are mutually exclusive procedures, meaning one can qualify for one and not necessarily the other, what would you recommend for the so-called borderline resectable hilar cholangiocarcinoma? That it's sort of creeping up as a bismuth 4. You think as a surgeon you'll be able to resect it. You're worried about vascular invasion. Should we be thinking about transplant for these patients up front, or should resection be still the gold standard?
Well, as I've tried to show, it really is not clear. And also then there are challenges. You're biopsying, you may preclude patients from transplant. And patients are often stuck in this realm where you counsel them, this may be operable, high chance of unresectability. And yet are you going to go to a center for a protocol for transplant? So there's no clear answer for that. And often when the patients are in that very borderline where you're worried that there's going to be high risk for unresectability, probably a transplant protocol is a good strategy, but at least in the U.S. and I think worldwide, it's a very limited resource for this disease, and so I think it's probably not a useful strategy to get patients enthusiastic about that potential approach.
Thank you for a very informative presentation. I'm a radiation oncologist, so I often confronting the patient's example such as R1 resection. Then what happens is that the site that we need a high dose radiation for some contamination margin, then still there's jejunostrum or something like that. So still there's a very serious limitation that can the high dose cannot be delivered. So what I suggest is that what about to consider more active adoption of neoadjuvant pre-op treatment using radiation. Also, when you say portal vein embolization, maybe you need to wait more for the liver hypertrophy. And the better thing with the radiation is that if we design radiation port properly, radiation can also induce significant liver hypertrophy for the future liver remnant area. Okay.
So you're saying, there you go, radiation can both help oncologically, but also elicit the contralateral hypertrophy. I mean, it's certainly interesting. We don't have good data on that. That is a concern. You have R1 positive at the margin. It's hard to know where to radiate postoperatively. There are risks with that, as you mentioned, irradiating the limb and so forth. And even the data on those patients who are R1 or R1N0, that delivering postoperative radiation, it's hard to look at the literature to show that delivering postoperative radiation improves outcomes in those patients. We often do that, but the evidence is not clear. That does lend enthusiasm to giving radiation neoadjuvantly, but again, hard to know about that data. We're very worried about anastomotic complications, even of preoperative radiation. That may be the direction to go, but I think it's still very controversial. Perhaps anyone from the audience could make a comment on the role of preoperative radiation?
So, Mike, I'll mention the postoperative radiation. Yeah. The SWOG 0809, I think, that study was 3 months of GEM-CAPE followed by chemo-RT. And they showed that in that study, the recurrence-free survival for R1 was equal to the recurrence-free survival in the R2. It's a small study, but that was sort of the basis for adjuvant chemo-RT. Now, my question to you is that, often we get patients from the community who have had really none of the kind of resections that you do. Just have like a palliative ductal resection and anastomosis and positive margin. So what do you recommend after that? Do you do a completion operation or?
I don't. Just the HighLow resection, both margins are positive or who knows what. I think that's a disservice to the patient to have undergone that operation. That's this fear of doing major hepatectomy, I think, and not adequate preoperative planning. I would say that would be, if the final pathology came back, one margin on one side was positive and the other was negative and everything else, I think one could perhaps make a case for taking them back and doing the hepatectomy. I must say I'd be reluctant to do that given the pattern of recurrence that those patients probably have oncologic high risk, and that would be a challenging operation to re-resect that. But I think that's certainly an option. I think most of the time it's going to be radiating those patients.
I think in the interest of everyone's lunch, we'll move on to the next speaker. Thank you.